Uh, Good evening, everyone. Welcome you all to the monthly classroom session that is being coordinated by Spice Road Kerala for the month of June. We didn't have much of activities for last 2 months, but we are coming back in full swing from this month onwards. So today we have an interesting case presentation on respiratory system that is being coordinated by Department of Family Medicine and Pulmonology from MGM Muthoot Hospital, Pathanamthitta. For welcoming the gathering, I welcome Dr. Nikesh.
Thank you, Dr. Vishnu. Good evening, all, and a warm welcome to all those who have joined today for an interesting case presentation in pulmonology. We have with us to moderate the session Dr. Nikhila Govind, who has passed MPBS from Government Medical College Trivandrum in 2007. She has done her MD pulmonology from Kottayam Medical College in 2011 and has completed her DNB in 2013. She became a member of FCCP in 2015 and got a diploma in allergy and asthma from CMC Vellore in 2015 and has got that FICM degree from Apollo Hospitals in 2016 and European degree in adult respiratory medicine in 2022. A warm welcome to ma'am. She has been working in MGM Muthoot for the last 9 years, and she has many national attended and presented paper in many national and international conferences. A warm welcome, ma'am. And we have with us Dr. KB Harish Kumar. Currently, he is a DNB resident in MGM Muthoot, Pathanamthitta. He will be engaging us for the next 1 hour with a wonderful case presentation. And I also welcome all those who have attended this session. Over to you, ma'am.
Hello, good evening to all. So today we have a case presentation in respiratory system. So we have Dr. Harish to present the case. So over to you, Harish. You can start presentation now.
Thank you, ma'am. Thank you, sir, for the introduction.
Okay.
Good evening, everyone. Today, our case presentation is regarding respiratory system, and I would like to present the case of a 47-year-old male patient who is a police constable by occupation, resides in Rani, and who belongs to a upper middle class socioeconomic status according to Kupusamy classification. And he came with the chief complaints of fever for 5 days and cough for 5 days and breathlessness for 1 day. And he was apparently asymptomatic 5 days ago. Then he developed fever, which is sudden in onset and high grade and continuous present throughout the day, which is associated with the chills and rigors and which is relieved by taking NSAIDs. And then he developed cough, which is sudden in onset and gradually progressing and which is productive in nature, and it is produced scanty and 2 teaspoonful and mucopurulent sputum, yellowish in color, which is non-foul smelling, no aggravating and relieving factors, and no diurnal and postural variation is seen. And then he developed breathlessness, which is insidious in onset and gradually progressive, and which is of grade 2 MMRC, and there is no diurnal and postural variation. And there is no history of recurrent cold and sore throat, no stridor, no hoarseness of voice, no hemoptysis and wheezing, and no history of palpitations, chest pain, orthopnea, paroxysmal nocturnal dyspnea, syncope, pedal edema, and giddiness. And there is no history of weakness, seizures, headache, altered mental sensorium, neck stiffness, and loss of consciousness. And there is no history of nausea, vomiting, dysphagia, abdominal pain, melena, loose stools, and abdominal distension. And there is no history of any decreased urine output, nocturia, or dysuria. And there is no history of weight loss and anorexia. And there are no similar complaints in the past. And he is a known case of type 2 diabetes mellitus and since 10 years, and he is on OADs. And there is no history of any TB, asthma, COPD, hypertension, coronary artery disease, or hypo or hyperthyroidism and epilepsy. And there is no history of any allergy. And there are no similar complaints in the family, and no known case of TB, hypertension, diabetes, bronchial asthma in the family. And he is taking metformin 500 mg daily, twice daily since 10 years. And he consumes a mixed diet, and his appetite is decreased since 5 days, and sleep is adequate, and bowel and bladder movements are regular, and he consumes alcohol occasionally, and he's a smoker who smokes 10 cigarettes per day. He's smoking since 25 years, and his pack years are 12.5 pack years. And he belongs to upper middle class socioeconomic strata according to modified Kuppaswamy classification. And on general examination,
Stop there. So by having a proper history of the patient itself, we can arrive at a diagnosis in about 80 to 90% of patients. So it is very important that the patient is in a mental condition to give the history in a proper way, and it's very essential that we approach it in a proper fashion. So first we will go to the history of presenting complaints. What are his chief complaints?
ma'am, chief complaints are fever since 5 days, ma'am. Fever for 5 days, and cough for 5 days, and breathlessness for 1 day, ma'am.
Okay, what are the major causes of cough? A 5-day cough, what all things will you think of?
Ma'am, any upper respiratory infections like pharyngitis, laryngitis, laryngotracheobronchitis, or any foreign body in the upper respiratory tract like the trachea, or any lower respiratory infections like pneumonia and COPD, acute exacerbation of COPD, and asthma, any occupational disorders like pneumoconiosis.
No, see, this is a cough associated with fever. So first we will be thinking about the infections, either in the upper respiratory tract or in the lower respiratory tract. And since it's of a short duration, it could be either viral or bacterial. So we'll be thinking like that. So what about, can you please show the elaboration of the symptom cough?
Yes, ma'am. Cough,
Okay,
which
this one,
is
productive cough, right? And you have
yes,
written
ma'am.
candy sputum. So what does this copious sputum mean?
Ma'am, sputum which is more than 30 ml per day is called copious sputum.
Okay, if it is less than that, we will say it is scanty, right?
Scanty
So
sputum.
you
Yes,
have
ma'am.
asked for a purulent sputum. Okay, in which all condition purulent sputum is seen?
Purulent sputum is seen in bacterial infections. Ma'am. Bacterial infections causing pneumonia.
Okay. Most commonly
Yes,
in
ma'am.
bacterial infection, but very rarely it can be seen in eosinophilic infiltration of sputum also. So
Yes,
you have
ma'am.
written non-foul smelling. What is the significance of foul smelling in this patient?
Ma'am, foul smelling sputum is seen in necrotizing pneumonias, lung abscess, and in any anaerobic infections, ma'am.
Anaerobic infections, yes. And no
Yes,
aggravating and relieving factors. What all aggravating and relieving factors did you ask for?
Ma'am, aggravated on taking any food, or aggravated on and relieving factors by taking any medicines. And
You have to ask if there is any aggravation on exposure to any cold or dust or any foul smell. Okay.
yes, ma'am.
Relieving factors, definitely you have to ask about the relieving medications, either inhalers or any cough syrup the patient is already getting.
Yes, ma'am.
And what is the significance of this diurnal and posterior variation in this patient? What is the significance
Ma'am,
of diurnal variation when you take a history of cough?
ma'am, in some conditions like asthma and COPD, there is a diurnal variation is seen, ma'am. In the night times and the early morning time, the cough will be more, ma'am.
And what about the posterior variation?
Cough will be more in the lung abscess and bronchiectasis. The cough will be more on the if uh, the patient turns onto the normal side, then the cough will be more, ma'am.
And this is a patient with fever and cough, product is sputum and all. What about sinusitis? What will be the presentation?
Ma'am, headache will be there, ma'am. Frontal headache will be there, sinusitis, and pain over the sinus tenderness will be there over the maxillary sinuses and over the frontal.
Postnasal dripping may be seen, right? Postnasal dripping may be
Ah,
seen. And
yes,
the
ma'am.
cough will be more on lying down position. Okay,
Yes, ma'am.
okay. And okay, so the history of cough is almost complete, excellently taken. Now, what about breathlessness?
Ma'am, breathlessness is insidious in onset, ma'am, which is of MMRC grade 2, ma'am.
So, what are the MMRC grades of dyspnea?
Ma'am, grade 0 is dyspnea developing during a strenuous exercise, ma'am. Grade 1 is when walking up a slight hill, and grade 2 is when the patient gets dyspneic uh, and he walks slower than the people of the same age or walks slower than their own pace previously when they used to do. And grade 3 is stops for breathing after walking about 100 yards, ma'am. And grade 4 is the patient is very dyspneic to leave the house and to do normal dressing also.
Yeah, it will be dyspneic at first, right? So,
Yes, ma'am.
what about the diurnal variation of breathlessness?
Ma'am, dyspnea is more in asthma and COPD patients. The dyspnea is more during the night time, ma'am.
Okay. And what about posterior variation?
Postural variation, dyspnea is more in some patients, dyspnea is more in lying down position, and in some patients, dyspnea is more in the uh, sitting position. Some patients, it is more on the lateral recumbent position.
So, what all conditions will cause an orthopnea in lying down position?
And orthopnea, like congestive cardiac failure,
Okay.
left ventricular failure, and ascites, and diaphragmatic palsy,
Okay. And what about
and pleural effusion.
now pleural effusion? There may not be an orthopnea. And what about what is autodeoxia? Do you know what is autodeoxia?
Orthodoxia.
What is tripopnea?
Yes, ma'am. Tripopnea is breathlessness in sitting position, ma'am.
It is
Sitting
in a
position.
lateral decubitus
Sitting.
position. Okay, lateral decubitus position. If the patient is having a one-side pulmonary pathology, then when the patient lies on the same side, the patient will be having dyspnea, like in collapse, pleural effusion, pneumothorax, etc. When the patient lies on the affected side, there will be severe dyspnea. And orthodoxia means the patient is able to lie down in a peaceful manner, but he won't be able to sit up. It is usually seen in pulmonary AV malformations. Okay.
Yes, ma'am.
Now more. Okay. What are other things associated history did you ask for? Next slide.
Ma'am, no history of recurrent cold and sore throat,
Why did you ask for that?
and any allergic conditions
Okay.
like
And why did you
allergic
ask for
rhinitis,
spider and hostess of voice?
stridor, to rule out any laryngeal causes, ma'am.
Laryngeal
Laryngeal
infection. Okay.
infection.
Hostess of voice also may be seen in this laryngeal cause
Lar-
as well as postnasal dripping. So
Yes,
you
ma'am.
have asked for hemoptysis, right? What is hemoptysis?
Coughing of blood is called hemoptysis, ma'am.
So, what are the common causes of hemoptysis that you see?
Acute bronchitis, pneumonia, lung abscess, and TB, lung carcinoma.
So last 2 points should not be missed out. Even though the most common cause of hemoptysis is an acute bronchitis, you should always be considering the differential diagnosis of lung malignancy as well as TB whenever you deal with a patient with hemoptysis. Okay.
Yes, ma'am.
Why did you ask for wheezing?
Yes, ma'am. Wheezing is seen in asthma and COPD, ma'am.
Did this patient have, he did not have any wheezing, right?
No, ma'am. No wheezing is there.
Okay. And you asked for palpitation, chest pain, orthopnea, syncope, pedal edema, and giddiness. Why did you ask for all that?
To rule out any cardiovascular causes of breathlessness, ma'am.
Okay. Okay. And what about weakness, seizures, headache, and all?
Ma'am,
Can altered sensorium be seen in any respiratory causes?
yes, ma'am. When there is a severe hypoxia, that can lead to hypoxic encephalopathy, ma'am. Altered mental sensorium can be seen.
In severe CO2 retention also, this altered mental sensorium can be seen, right?
Yes, ma'am.
As well as in patients with pneumonia, sepsis, and all, altered mental status will be seen. And
Yes.
why did you look for neck stiffness and loss of consciousness? Loss of consciousness, okay. Hypoxia, hypercarbia, all that can cause. Neck stiffness, why did you look for neck stiffness in this patient?
And meningitis can be caused due to the infection secondary to pneumonia, ma'am.
Okay.
It can complicate meningitis. So meningism can be seen. So to rule out that, yes, ma'am.
Sometimes inflammation of the meninges can occur without actually infection. So that also will cause a neck stiffness. So okay, so there is no history of neck stiffness, and you have ruled out an abdominal cause also, right?
Yes, ma'am.
There is no nausea, vomiting, abdominal distension. Okay. And did you ask for a decreased urine output? Yes. What is the significance of asking about decreased urine output in this patient?
Ma'am, sometimes the patient complication of some infections will be shock, and the patient may go into shock, and decreased urine output can be seen, ma'am.
Acute kidney injury. This is a patient with a respiratory infection, right? So acute kidney injury can occur, and which will cause a decreased urine output. And you have also asked for weight loss and anorexia in this patient. What is the significance of both that?
Weight loss is seen in TB and some carcinoma of the lung and some any nutritional disorders. And in this patient, weight loss is to rule out carcinoma and TB, ma'am.
Yeah, this patient is a chronic smoker. So this could be a respiratory infection complicating a malignancy, underlying malignancy. So the history of weight loss should be sought for. Okay. Okay.
Yes,
next slide.
And
So
there is no similar complaints in the past.
No similar complaints in the past. Why did you ask for that?
Ma'am, sometimes in COPD patients, they are more prone for infections, ma'am. Repeated recurrent infections.
Also, this is a patient with a smoking history. So in such patients, recurrent infections can occur as a result of underlying malignancy. So similar complaints in the past is very important.
Yes, ma'am.
And also he's a non-type 2 diabetic patient, right? So you asked TB, asthma. Asthma, what all things did you ask for, whether to find out if the patient is having asthma or not?
I asked him whether he had any acutely breathlessness in the past, and he had to use any inhalers in the past, and when was it started, if so. But
Any
it was
allergy,
not there.
history of any allergy, nasal allergy like that. Okay, and what about COPD? How did you assess the patient, whether the patient is having COPD or not? If it is a case of emphysema, the patient will be having exertional dyspnea for a prolonged period for more than 2 years. And
Yes, ma'am.
if the patient is having a chronic bronchitis, then they will be having this typical productive cough for 3 months for 2 consecutive years. So in that way, you have to, and also you should ask whether the patient is using any inhalers. Okay.
Yes, ma'am.
Okay. Then hypertension. Hypertension is also significant. The patient is having dyspnea, so hypertension is significant. Then coronary artery disease. Okay. Okay. So next slide, please.
Yes, ma'am.
Okay.
No similar complaints in the family.
Okay.
So, and he's not a no known case of TB, diabetes, hypertension, bronchial asthma in the family.
Okay.
And he's taking metformin 500 mg twice daily, ma'am.
Okay. Okay. Next slide, please.
Yes, ma'am. Personal history: he consumes mixed diet and decreased appetite is seen since 5 days. Ma'am. And sleep is adequate, and bowel and bladder movements are regular, and he consumes alcohol occasionally, and he's a smoker. Ma'am.
What is the
He
significance of alcohol consumption in pneumonia in such patients? What is the significance of alcohol consumption?
And alcohol decreases the immunity, ma'am, and patients are more prone for getting infections, ma'am, respiratory infections.
Particularly Klebsiella infection, anaerobic infection and all. Particularly
Yes, ma'am.
Klebsiella infection. They are more prone for chronic alcoholics are more prone for developing Klebsiella infection. And about smoking also, what is pack here? What does the word pack here mean?
Number of pack of cigarettes smoked per day into multiplied by number of years smoked, ma'am. Each pack is taken as a 20 per pack, ma'am.
So
20
what is the
cigarettes per pack.
significance? What is the significance of pack years?
Ma'am, if the pack years are more than 40, then they are more prone to develop bronchogenic carcinoma. If it is more than 20, then the patient is more prone to develop COPD. Ma'am.
Okay, next slide, please.
And he belongs to upper middle class socioeconomic strata. Ma'am.
Okay, particularly if there is overcrowding and all, there is high chance for getting recurrent infections and TB.
Yes, ma'am.
Okay, you should know about the definition of overcrowding.
Yes, ma'am.
Okay. Next slide.
General examination.
Okay. What all differential diagnosis will you consider? You have taken a very good, excellent history. So, what all differential diagnosis will you consider at this point?
Ma'am, pneumonia.
What all
Acute pneumonia.
differential diagnosis? What all things will you consider in this patient?
Like the patient is having a cough, ma'am, fever, which is high grade and continuous in fever, and next cough, which is mucopurulent and yellowish in color, and then dyspnea, which is of grade 2, and who is a smoker and diabetic, ma'am. So all these factors lead to more prone for the patient developing pneumonia.
Pneumonia. It could be LRP alone, right? It could be a bronchitis. Could be a pneumonia.
Yes.
Okay. Now we'll move to the examination. Okay. General examination.
Yes, ma'am. On examination, on general examination, patient is toxic, ill-looking, and he is conscious, cooperative, and well-oriented to time, place, and person, and is in supine decupidus, and he is well-nourished and moderately built. His BMI is 23. And what else? Pulse rate is 107 per minute, and which is regular in rhythm, normal volume and character, normal blood vessel wall thickening, all peripheral pulses are felt, no radiofemoral delay, no radial delay is present, and BP 130 over 80 mmHg in the right arm in the sitting position, and respiratory rate is 28 per minute, abdominothoracic, regular in rhythm, and temperature 101 degrees Fahrenheit, and SpO2 95% in the room air, and JVP is not elevated.
Okay, so first is pulse rate. What is the normal pulse rate?
Normal pulse rate.
When will you say there is tachycardia? When will you say there is tachycardia?
Tachycardia is seen in fever, ma'am. Fever, acute conditions.
When will you say it is tachycardia? More than what?
More than 100, ma'am. More than 100 100 is called tachycardia.
Okay, okay. Then what about respiratory rate? When will you call, what is the normal respiratory rate?
And 12 to 18 is a normal respiratory rate, ma'am.
And when will you say there is tachypnea?
When the rate is more than 20, it is called tachypnea.
So the patient is having abdominal thoracic breathing. Is it normal for this patient?
Yes, ma'am. Abdominal thoracic is normal in males.
Oh, yes. Where are this thoraco-abdominal breathing seen?
It is seen in females, ma'am,
And children.
and
Okay.
children.
And you
Yes.
written regular rhythm. Do you know any abnormal respiratory rhythm?
Yes, ma'am.
Okay.
Biot's breathing,
Micros
which is
breathing.
irregular in rhythm, which is seen in meningitis, ma'am. And chain Stokes breathing, which is increase in rate and depth of the breathing, which is seen in metabolic acidosis and diabetic ketoacidosis and lactic acidosis.
Case of breathing is seen in this central apneas. Central
Yes, ma'am.
apneas, congestive cardiac failure, high altitude, etc. Okay.
Yes, ma'am.
Okay. Then saturation is 95. What is the normal saturation?
Normal saturation is 95 and above is normal saturation.
Okay, okay. JVP is not elevated. Why have you specifically mentioned JVP?
To rule out any cardiac causes, ma'am. Cardiac causes of breathlessness.
Okay, good.
And
Next slide.
there is no pallor, no icterus, no signs of clubbing, cyanosis, no generalized lymphadenopathy, no edema, and IV catheter is present on the left hand dorsal arch vein.
So what is the, why did you look for clubbing in this patient?
Clubbing is seen in some conditions, ma'am. In some chronic conditions like lung carcinoma, bronchiectasis, and
Say this patient got admitted.
lung abscess.
Lung abscess, yes. Initially, if you are not having clubbing, and later on after 1 week, if he is developing clubbing, we have to see whether this patient is having lung abscess or empyema.
Lung abscess. Yes.
And always that differential diagnosis of bronchial carcinoma has to be kept in mind. Okay.
Yes, ma'am.
Okay, next slide.
Head to foot examination. Hair is normal, eyes are normal, and face is normal in symmetry, and no edema is there. And neck is normal without any thyroid and lymph node swellings, and upper and lower limbs are normal. And systemic examination, I would like to examine upper respiratory tract, ma'am. I would like to examine respiratory tract, respiratory system, because the symptoms and the findings and the history suggest me to take respiratory system examination. And ears are normal, and nose is normal without any nasal flaring of LNSI, no DNS, and no polyps, no nasal discharge. And oral cavity is normal teeth, and gums, normal tonsils and pharynx, and no sinus interference is present. On inspection, trachea is central in position, and examination of the chest, shape is elliptical and bilaterally symmetrical, and movement is equal on both the sides. Apical impulse is not visible, and respiratory rate is 28 per minute, which is regular. And the accessory muscles, sternocleidomastoid is prominent, and skin is normal without any scars, sinuses, engorged veins, subcutaneous nodules, swelling, no intercostal narrowing, and no wheezing, stridor, or other sounds are audible. And spine is normal now.
Okay, next slide.
And on palpation, all the inspector findings are confirmed, ma'am. Trachea is in central position, and no local rise of temperature, no tenderness is present over the chest, and apex pit is felt medial to the left fifth intercostal space, mid-clavicular line, just medial to the mid-clavicular line, and no parasternal heave is present, and chest movements are symmetrical on the both sides, and chest dimensions are AP diameter 21 centimeters, and transverse diameter is 30 centimeters. Expansion of the chest is 4 centimeters, inspiration 92 centimeters, and expiration 88 centimeters.
So no local rise of temperature, no tenderness. Why is it significant in the case of respiratory system?
Ma'am, local rise of temperature is seen in empyema, ma'am. Empyema. empyema thoracis,
Tenderness also
And-
is in the same, right?
yes, ma'am. Tenderness is also.
And what is the significance of trachea and apex beat being central?
Trachea is moved towards lateral side in some conditions, ma'am. In collapse of the lung, the trachea is moved towards the side of the collapse, and in pleural effusion, the mediastinum is pushed to the other side so that the trachea will also be placed laterally.
Okay. Can you mention some other conditions in which the mediastinum is shifted to the same side of the lesion?
Fibrosis.
Fibrosis, yes.
Yes.
And in massive pleural thickening also.
Yes.
Okay. Then what about tracheal and apex beat shift to the opposite side?
Ma'am.
What about mediastinum shift to the opposite side? Can you mention some other conditions other than pleural?
Pleural effusion, pneumothorax, ma'am.
Yes.
Pneumothorax
Mhm.
and hydropneumothorax.
Okay.
Yes.
And large mass lesions. Also,
Large mass.
large mass lesions also can cause the tracheal and apex beat shift to the opposite side.
Yes, ma'am.
Okay. And what about the expansion of chest? What is the normal expansion of chest?
Normal expansion of the chest is 5 to 8 centimeters, ma'am.
It is 5 to 7 or 5 to 8, 5 to 8 centimeters. And didn't you mention this hemithorax?
No, no.
That is also important. Measuring the hemithorax that will help us. If there is a decreased movement on one side of the chest, that will help us to identify the site of lesion. Okay, so that's also important. How to assess the expansion of hemithorax. Okay.
Yes, ma'am.
Okay. Next slide.
Ma'am, vocal femtus is increased in the right infraaxillary area and interscapular area and infrascapular area. Friction femtus and spine is normal.
What is vocal fragmentus?
Vocal femtus is palpation of the sound vibrations from the palpation of sound vibrations on the chest wall.
Sound vibrations produced by larynx over the chest wall.
Chest
So,
wall. Yes.
what are the causes for an increase in vocal fragmentus?
Vocal femtus is increased in consolidation of the lung and above the level of the pleural effusion. And mass overlying
And
a patent bronchus.
over a patent bronchus. And what are the conditions which will cause a decreased vocal fragmentus?
Decreased vocal femtus is in pleural effusion, pneumothorax, ma'am.
Okay. And also in pleural effusion, right?
Yes, ma'am.
And in collapse, fibrosis.
Collapse fibrosis.
In very large mass lesion.
Yes, ma'am.
Okay, in such cases and in pleural thickening and in such cases vocal fragmentus will be decreased.
Yes, ma'am.
Okay, so next slide.
Percussion.
Okay.
Percussion on the clavicle is resonant and on the chronic isthmus is resonant, and dullness is noted on the right infraaxillary area, interscapular area, and infrascapular areas. And hepatic dullness is noted in the right 6th intercostal space in the midclavicular line. And rest all other areas are resonant, and tropic space is resonant.
What sort of dullness did you get? Was it what type of dullness did you obtain?
Woody dullness, ma'am.
It was not stony dull, right? Woody dullness was there.
No, no.
Next slide.
On auscultation, bronchial pressures are heard in the right infraaxillary, interscapular, and infrascapular area, ma'am. Fine crepitations are heard over the infraaxillary, lower interscapular, and infrascapular area. And normal vesicular pressures are heard in all the other areas. And vocal resonance is increased over infraaxillary, interscapular area, and infrascapular areas. Whispering pectoraloquy and egophonia are heard in the right infraaxillary and right lower interscapular area and infrascapular areas.
So what are these? What is the normal lung sound?
Vesicular breath sounds, ma'am.
So how will you differentiate between vesicular and bronchial breath sounds?
Vesicular breath sounds. In vesicular breath sounds, the inspiration is more than the expiration duration, ma'am. And there is no gap is present between the inspiration and expiration. And while in bronchial breath sounds, the expiration is longer than the inspiration, and there is a small gap
No, the
between the
expiration will be
inspiration.
longer, but not longer than the expiration. Expiration will be longer, then there will be a
Yes, ma'am.
pause.
There is
in
a
between,
gap,
gap in between.
pause in between the inspiration and expiration.
Okay, in which all conditions will you get a bronchial breathing?
Bronchial breathing is seen in pneumonia, ma'am. Pneumonia
Okay,
and or the lung cavity,
okay.
and
It can also be heard on the upper level of pleural effusion due to a relaxed lung.
yes, ma'am. Upper
Okay.
level of pleural.
Okay, and you have heard crepitations. What are crepitations?
Crepitations are discontinuous crackling sounds heard, ma'am.
Okay,
Crackling sounds.
okay. Due to sudden pop opening of the already closed airway, right? So in which all
Yes.
conditions will you hear crepitations?
Crepitations are heard in pulmonary edema
Okay.
and pleural effusion,
In pleural effusion,
bronchiectasis,
yes. In pneumonia, right?
pneumonia,
Pneumonia, then pulmonary edema,
interstitial lung disease, fibrosis,
fibrosis, yes. Bronchitis, lung abscess, suppurative
bronchiectasis.
pneumonia. In all those things, crepitations will be there. Is there any other added sounds, adventitious sounds, you know?
Yes, ma'am. Stride, wheezing, ronchi.
Ronchi. Okay, what does this
Ronchi.
ronchi mean?
Ronchi is a continuous musical sound, ma'am. Musical sound heard.
Where will be ronchi heard?
They're heard in asthma and COPD, ma'am. Bronchitis.
Bronchitis is also acute bronchitis, asthma, COPD, bronchitis. Sometimes in bronchitis. Usually in asthma, COPD, and acute bronchitis. Okay. Then you have said vocal resonance, like vocal resonance is just like vocal phragmatosis, auscultatory counterpart of vocal phragmatosis. And what
Yes,
is meant by whispering petrology? How did you elicit that?
Whispering petrology is patient is asked to murmur inside, murmur one,
Whisper. Okay.
and
Okay.
whisper, not to speak loud, and we can hear the sounds distinctly and clearly, ma'am.
Okay.
On auscultation.
Okay.
That is called whispering petrology.
Where will that be heard?
It is heard in consolidation.
And what about egophony? You mentioned egophony also. What is egophony?
Egophony is it is a qualitative change in the vocal resonance, like a nasal bleating of a goat, ma'am, with a nasal intonation like that.
Yeah, nasal qualities are imparted to the resonated sound, right?
Yes, ma'am.
Okay. In which condition will this egophony be heard?
It is heard in consolidation, ma'am. Consolidation.
Okay, next slide.
And on the other system examination, cardiovascular system, S1, S2 are heard, and no murmurs are present. And CNS, no facial asymmetry, all reflexes are normal, no neck stiffness, and normal tone and power of the muscles. And GIT, per abdomen is soft, non-tender, and bowel sounds are present, and no hepatosplenomegaly and no ascites is present.
Okay. Can you summarize your clinical findings?
Yes, ma'am. The patient, 47-year-old male patient who is a active smoker and a known case of diabetes.
No, the clinical findings. Clinical findings.
Yes, ma'am. On examination, the patient is looking ill-looking, and toxic, and he's having tachycardia, tachypnea, with accessory muscle prominent,
So what?
and on palpation,
Okay, on palpation.
decreased expansion of the chest. Decreased expansion of the chest is present, and vocal tremulous is increased in the right intraaxillary, interscapular, and infrascapular areas,
Okay.
and increased vocal resonance. And on percussion, dullness is noted on the right intraaxillary, interscapular, and infrascapular areas, and increased vocal resonance is heard over the infraaxillary, interscapular, and infrascapular areas, and fine crepitations are heard over the right intraaxillary, lower interscapular, and infrascapular areas. Whispering, picturloquy, and egophony are heard in the infraaxillary, lower interscapular, and infrascapular area.
So what diagnosis did you obtain?
Ma'am, it is most likely to be a pneumonia, ma'am.
Consolidation. A consolidated.
Consolidation of the right yes, ma'am, right lower lobe consolidation.
Okay. And was there any complications?
There are no complications, ma'am.
What are complications will you look for?
Complications like pleural effusion, lung abscess, and myocarditis, pericarditis, and any meningitis,
Empyema,
and sepsis, empyema, and sepsis,
respiratory failure,
shock,
very important, right?
respiratory failure. Yes, ma'am.
And shock.
Sure.
Okay, so how will you approach this patient?
Ma'am, first basic investigations like hemogram need to be done. Hemogram will show leukocytosis and increase in ESR, inflammatory markers like ESR will be there. And next, I would like to do a COVID RT-PCR to rule out any COVID-19 infection, COVID pneumonia, and then I would like to go for nose and throat swab now. Throat swab to for culture to see for any virus culture, and then I would like to go for sputum gram stain and sputum culture AFP and CB net. And then I would like to do a radiological examination like chest X-ray.
What are
To
things
see for
what are things are you expecting to find in a chest X-ray in a patient with differential diagnosis of pneumonia?
Pneumonia, opacification is seen. Opacification will be seen
Okay.
in the area of consolidation.
Okay.
And then I would like to do a
What is air bronchogram sign?
air bronchogram. It is a air-filled bronchi. Air-filled bronchi on a background of an opacified lung.
Okay, okay. So in what all conditions will you get this air bronchogram sign?
It is seen in broncho. It is seen in pneumonia.
Okay. It may also be seen in pulmonary edema, a malignancy like PAC, bronchoalveolar carcinoma. Some types of ILDs also this air bronchogram sign may be seen. So by looking at the air bronchogram sign alone, you cannot say that it's an infection. You have to correlate it with the clinical and this history, clinical findings as well as the history. Okay. Then how will you proceed?
And then I would like to, in hospitalized patients, if the sputum culture does not give any culture, and then I would like to go for a blood culture, and then serological tests for detecting pneumococcal, mycoplasma, coxiella, and chlamydia antigens. And then I would like to do ABG, ABG and pulse oximetry to see for any respiratory failure. If the patient is having any severe hypoxia, then I would like to do an ABG. And then I would like
After
to
it is less
do
than 92, you have to do an ABG.
so
Okay, then
then I would like to do CT scan. Uh,
will
if
you
the
do CT
patient is
scan routinely for all patients?
no, ma'am.
Okay,
If the patient is severely sick, and then hypoxia is there, and if the patient is having if we suspect any other tumors occluding the bronchus, then we will do the CT scan.
okay. So if in the chest X-ray we are suspecting any nodules, or if the
Not
if the patient is not having a proper resolution. So
yes,
what is this non-resolving pneumonia?
no, non-resolving pneumonia is uh, less than after 2 weeks of treatment. Also, if the reduction in pneumonia is less than 50%, radiological clearance of pneumonia is less than 50%, or incomplete clearance by 6 weeks of treatment, then it is called as a non-resolving pneumonia.
Okay, okay. Then how will you proceed? Okay, you had done the CT also, and now we are seeing a lesion. In the your case is a right lobar pneumonia, no? So you are seeing a lesion in the right lobar bronchus. How will you proceed then?
Then I would like to add an first general manner. I would like to do
First you will, so if we are seeing a lesion in the CT chest, after stabilizing the patient, then we will go for a bronchoscopy.
bronchoscopy. Yes, ma'am.
Bronchoscopy, okay,
Bronchoscopy.
okay. And then how will you manage this patient? This is a case of pneumonia. So how will you manage a case of pneumonia?
Firstly, generalized general treatment like IV fluid management
Okay.
to
So first
correct
we
the
will see the
dehydration.
patient. First we will see the patient and we will determine the curve 65 score, right?
Yes, ma'am.
What is curve 65 score?
Curve 65 confusion. It is curve 65 is used to assess the severity of the patient, ma'am, whether to treat in the on the OP basis or in the hospital IP patient. So we can analyze it based on the score, and the factors are confusion, uremia, respiratory rate, and BP, and age more than 65 months.
Okay. So how will you decide where to manage?
If the score is 1, then it can be treated on the OP basis, ma'am. If the score is 2 to 3, then depending upon the patient, we can in the hospital setting as an IP patient, and if it is more than 3, then we will admit in the ICU and treatment in the
Okay.
intensive care.
So we are decided to hospitalize this patient. Okay. And you see that then what else will you do? You will first assess the hypoxia, right? And if the patient
Yes,
is
ma'am.
having a hypoxia, you will immediately start the patient on oxygen.
Oxygen inhalation.
Okay, that's the first thing to be done. Okay, then
Then hydrating the patient, because the patient may be having hypotension and dehydration, and definitive management is through antibiotics, ma'am. In bacterial pneumonias, pneumonia caused by bacteria, antibiotics are to be given, and antibiotics like in community acquired pneumonias, the antibiotic of choice is beta lactam antibiotic, beta lactam plus a macrolide antibiotic, ma'am.
okay. Then
And in hospital acquired infections, the antibiotic of choice would be to add third generation cephalosporin plus a fluoroquinolone.
fluoroquinolone. So in India, before adding fluoroquinolone, we have to rule out tuberculosis.
Yes, ma'am.
Tuberculosis. Okay. And what about if the patient is very sick, like the patient is having severe hypoxia, hypertension, severe hypoxia refractory to the oxygen and the positive pressure treatment, then we will go for a mechanical ventilation, right?
Yes, ma'am.
And if we have to closely monitor the patient for the development of lung abscess or any other complication. And if the patient is having suppurative pneumonia or if the secretions are copious, then we should ask them to get a just physiotherapy done.
Yes, ma'am.
Okay, so this comprises, so this is the management of pneumonia. Do
Yes,
you want any further questions or shall we wind up now? What is the classification of pneumonia?
Ma'am, it is classified based on the mode of acquiring the infection, like community acquired pneumonia, hospital acquired pneumonia, and pneumonia in the immunosuppressed ma'am. And based on
So why
the
are we dividing the
etiology
pneumonia like that? Why do we divide pneumonia like that?
and the treatment management will change depending upon the
The antibiotics will change, definitely change
antibiotic.
upon
Yes,
what type of pneumonia the patient has acquired. Okay. So Harish, that case was excellently presented. You have missed only 1 or 2 points. That the clinical history was complete and the case was excellently presented. Very well done, Harish. Okay.
Thank you.
Dr. Mamta, can we conclude the session?
Good evening, all. Am I audible?
Yes.
Yes, ma'am.
Thank you so much, Nikhila ma'am, for taking the time out of your busy schedule and sharing the session so well. I'm sure it is very useful for all the postgraduates and even the practicing physicians. Thank you so much, ma'am, and we hope to see you again in our future academic sessions as well. I also thank Dr. Harish, who has presented the case so well. He has gone into each of the minute details, even in the history as well as in the examination. And all the questions which you have asked was also very rightly answered. So thank you so much, Harish, for presenting the case so well. I thank all the participants who have joined the session and wish you all a happy Doctor's Day. Thank you.
Thank you, ma'am. Thank you.